Welcome to In Your Neighborhood. I'm your host, Chris O'Rourke, as we continue our special series, Conversations on COVID-19. And we are very honored today to have the leaders of our local healthcare systems. We have Kendra Acker, the president and CEO of Evangelical Community Hospital in Lewisburg. Welcome, Kendra. And we also have Dr. Jaewon Ryu, the president and CEO of the Geisinger Health System with us today. Welcome, Dr. Ryu.
Thank you, Chris.
Okay, so let's get started with the most recent news, which I'm sure was good news for you, which is the fact that the governor has said, go ahead and resume doing and scheduling and redoing elective surgeries. So we'll start with you, Kendra. How did you take that news? Very good news, I imagine.
Oh, it's very good news. Obviously, closing the ORs to elective cases really destabilizes the hospital economically. So the news that we can begin to ramp up is certainly positive.
How soon are you doing it? Have you already begun to schedule them already? And when do you know when the first one will start? And I imagine you might not have the number in your head, but what kind of a backlog you're looking at?
Sure. We're sort of doing this in a phased approach. So number one, I think, and Dr. Ryu will probably speak similarly to this, is that, 6 weeks ago, when you evaluated patients that could be delayed, they met the criteria to be delayed. But as time passes, those cases have been resuming anyway, because the person now meets the criteria to have the case done more on an emergent basis because they can't wait as long. So we have been seeing an increase in those cases this week beginning to come into the ORs. Next week, we have an endoscopy, a freestanding endoscopy center, and we have a freestanding surgical center. And so what we will do is, beginning next week, we will continue some of the cases in our regular operating rooms, and we will begin to open the endoscopy center 5 days a week and begin to do all of those procedures there. We can then keep those cases out of the hospital, the majority of those cases out of the hospital, and do them in our endoscopy center. Then the following week, which is the 11th, we will open up the Evangelical Ambulatory Surgical Center and be able to do orthopedic cases and general surgery type cases there. And we'll run that operation 5 days a week. And then in the ORs in the hospital, because we have to balance having COVID and non-COVID patients inside the facility, we will also do joints, hips and knees, those types of procedures. We'll do some of those cases. We'll have some gynecological cases that we're doing inside the hospital, but we'll be limiting the pace at which we do that on a daily basis in order to make sure we're safely taking care of patients when they come into the building. And then from a backlog perspective, we are backlogged hundreds of cases. And that is particularly for us in orthopedics, is where we've seen it. But we are seeing it in general surgeries, in gynecological type procedures. But, we are 800, 900 cases backlogged, particularly in orthopedics. So it will take us a little while to come out of it. And as you can imagine, the surgeons are ready to go, but it's a phased approach, and it's a phased approach as you try to bring your staff back. You can't just flip the switch and bring everybody back and not have the volumes to support bringing everybody back. So you have to kind of temper the workforce in how you come back and couple that with meeting the needs of the patients to get these cases done, and the desires of the surgeons to get working again at their full capacity. So it's kind of a balancing act, but it's really done to make sure you're taking care of people safely, whether you're doing it inside the walls of the hospital or outside in our two freestanding facilities.
Okay, Dr. Ryu, how is Geisinger beginning to start elective surgeries again?
Yeah, I think it's very similar to what you heard from Kendra, and I think she said many important things, and it's worth underscoring. One is safety rings true. I mean, that's got to be the North Star that guides us in terms of our approach. We believe, as Kendra alluded to, that there are plenty of ways to do this safely, to reintroduce the elective and cases that were previously non-urgent. But I think you heard Kendra mention, and we would totally agree, things that previously may not have been as clinically urgent they may have been able to wait a month, but as you get deeper into that time horizon, and now we're 6 weeks in, those things have an urgency now that they may not have had 6 weeks ago. And so it's an ever-changing landscape to reevaluate the cases that have been, postponed or rescheduled. And I do also agree with the fact that it's a phased approach. And so that's how we've been managing it as well. The concept being really in the coming weeks. And I think for us, probably won't start next week, although some cases might. It may be the week or so following, but at some point in the next couple weeks or so, we'll be reintroducing gradually. And I think it's not a light switch. It's got to be a gradual, phased and thoughtful reintroduction of which cases you do based on a combination of factors that we're trying to balance. The big one being clinical need and necessity and patient symptoms and urgency, but then also balancing that against things like our bed capacity, our equipment status, our the role of testing. I mean, there are a lot, and of course, staffing. I think these are all things that we're balancing because at the same time that we're doing these kinds of cases, there's still a whole host of COVID cases that we fully anticipate and are already seeing, depending on the specific geography you're talking about within the communities that we serve. And so it's taking all of those things into account and trying to be thoughtful about how we do that.
Okay, Dr. Rue, let's go back a little bit. When did you first hear about the novel coronavirus? And at one point, did you begin to pay attention to how it was being handled, I guess, overseas?
Yeah, so we had a emergency preparedness group that started looking at this and meeting with our infection control folks and the emergency preparedness, our folks in supply chain back in January. And they were preparing because I think every season they're always preparing for things like this. And this is a group that's used to thinking in terms of, well, what's the worst case scenario? What could happen that we need to be ready for? And so they've been probably prepping since that time. And the other group I'd throw into the mix is our laboratory team. And they were able to get us some early steps that got us pretty prepared, I would say. And the big one has been our ability to do our own testing on site. We were one of the first couple sites in the entire state that had the ability to do on-site testing. And what that allowed us to have happen was, at least for the most emergent cases where we needed the test result within hours as opposed to days, we were able to do that on site. And that allowed us to conserve our personal protective equipment, because when you're able to rule out these patients and know that they're definitively not COVID, you don't have to continue to use those resources on those patients. And instead, you're able to conserve them and use them on the patients who truly are positive. And so I think that was a good illustration of where our preparedness efforts dating back a few months really came through in a big way to help us manage our supplies and other dynamics related to this. I think the other was, as all health systems experienced, when you take out your elective non-urgent procedures and visits, there are areas of your operations that see a lot less activity. But at the same time, there are areas that see a lot more that are related directly more to COVID, whether it's the ICUs, the emergency rooms, or the hospital floors. And so we were able to redeploy and reassign, I should say, staff from the areas of lesser activity to the areas of more activity. And at this point, we've been able to reassign over 2,000 of our staff in that manner. And so it's allowed us to sort of nimbly move resources to the areas of greatest need.
Did you believe all along that you would have to deal with this?
We did. I mean, I don't know at what point we did, to be totally honest, but once it was stateside and you saw the early accounts of community-based spread, and I think the earliest cases were in the Seattle market, and then we started hearing about it in the New York metropolitan area. At that point, we knew that we would get this as well, just because of the natural migration of people in society today. It's an illustration of how the world is small and people are pretty mobile, and things that are hitting us in the Seattle market or the New York market, it's only a matter of time until it hits us more regionally and locally. And so we started tracking that. And sure enough, our Northeast area, whether Luzerne and Lackawanna counties, we saw the wave hit a lot sooner. We're still seeing a pretty significant number in those counties. And we believe, based on our data projections and our models, that the other areas will trail behind that by several weeks in a sort of sequential way, kind of moving westward. And we're fully prepared for that because I think that's an eventuality. Now, the good news is, due to the social distancing efforts and the precautionary efforts of the community, I think we've seen the projected peaks be a lot lower, and that it's pushed out more in time, which allows us to continue to get things in order by way of supplies, testing, equipment, and so forth. And so I think the system as a whole, I'm not speaking just for Geisinger, I really speak on behalf of the community, I'd say, because this really is an effort that involves all of us. And I know Kendra and I have discussions along those lines. We're all in this together. It's a community effort, and we know it's going to hit, but I think at this point we've gotten a handle on the key areas, and we're in a very different spot today than we were 5 weeks ago.
Kendra, what about you? When did you first hear about it? What point did you begin to pay attention to how it was being handled? And also, I'll just ask you the other question as well. Did you believe all along that you would have to deal with this?
Sure, I think we are very similar. I think my recollection was that in December, we began to really start to watch what was happening internationally, and then in January, begin to update our pandemic plan. So very similar. We have a standing pandemic plan, and you are always updating it based on what potential illness might be coming. And so this one happened to be very respiratory focused. So, we began to update our pandemic plan. I think I'm the same as Dr. Rue in that, once it hit the States, it wasn't a matter of being surprised. It was a matter of when we would see it, not if. So, we saw it fairly quickly once it began to hit, New York and New Jersey. And we had one patient come very quickly who was very sick. So it was really a matter of when it was going to happen. And I think one of the things I'd like to play off of is, Geisinger and EVAN, we are competitors, so to speak, in the region, but we are extremely cooperative. And you never see that greater than you do in the time of a crisis, because we are tasked with taking care of a community. And we got tasked with taking care of a community at a time when a local facility also had closed down. And so we've been seeing large increases, both of us, from the Sunbury and surrounding regions. So the nature in which we cooperate is important. And EVAN was not able right away. We now have the capability, but right away we did not have the capability to do on-site testing. And that had to do with the fact that we are small and we do not cover a large region or a large system, but we've now got that capability. But Geisinger was very cooperative and understanding and helping us each day do some rapid testing in order to better manage our patients, but also protect the staff and manage the PPE, so that if we could rapidly see that we had a patient that had COVID, great, we knew exactly what to do, but we would be isolating somebody and not know if they had COVID or not, and using PPE like they did. And so getting those rapid tests back really helped us better manage the patients. And we have a regional plan. If we were to have seen peaks, we know together how we would manage that population. And so I think that's oftentimes people miss that in how care is managed in a region. And we work very cooperatively together because we're both tasked, basically we work for the community, and that's what we're here to do, is take care of the community. So I think, that's really an important aspect of it.
How often do you two touch base with each other?
I would say early on we were talking quite regularly. When COVID hit, we meet routinely. Anyway, throughout the course of a year, we every quarter or so get together and have a cup of coffee or have dinner together and really just talk about healthcare in the region and ways in which we can be better serving the community together. And then through this, we were speaking every couple of days for a while, just making sure we were on the same page. And then it's eased up a little bit as our plans have fallen into place. Once a week is probably once every 10 days right now that we've been chatting. But we have each other on on speed dial on our cell phones.
And it's a meeting I always look forward to. And I'm looking forward to getting back to the grabbing dinner or bite to eat or coffee. You know, it'd be nice to get back to those times.
So Dr. Rutelis, what was your reaction? We already talked, you knew it was coming. What was your reaction when you heard you had your first case?
You know, in a weird way, the group had been preparing for so long. I think it may have even eased some of the anxiety of a lot of our staff, because the anticipation and the waiting, I think, creates a heightened anxiety. And so when we had our first case, I mean, obviously, that's never good news. But at the same time, I think the group felt pretty prepared. And the other thing that we should talk about here is, or mention, is the group had been through some readiness efforts of related scenarios in the past. Ebola was a good example where we had a biocontainment unit and team that was stood up as a result of that. And that same playbook was what we had dusted off as part of this. And so there was some muscle memory there that we were building off of, as opposed to just starting from scratch. And when we got the first patient, I think people felt like, okay, now we've been preparing, we've been doing the drills, the dress rehearsal, so to speak. Now's the real thing. And we knew it was going to be the first of many. And indeed, that's how it's played out. And that's okay if we put in the right precautions and the right processes and have the right equipment and supplies and have the right training. The rest kind of follows, and I think that's what we've seen thus far.
What about you, Kendra? Same case, that it was just the waiting was the hardest part, and then when it finally came, there was a little relief, maybe?
Sure. I mean, I think he hit the nail right on the head with that. I mean, and you also have to realize that you take people who are extremely busy all the time, and then they're preparing for something, and all of a sudden they're not doing their daily routine, and they're not seeing as many patients. And that's the case for the entire facility. I mean, the public stops coming into the emergency room, which stops sending patients upstairs to your inpatient beds. And so all these people that are notoriously busy are not, and they're thinking about this 100% of the time. And so, you know, your anxiety, your worries, you're wondering, have I done this right? And then you're hearing and reading the latest literature on what's happening. And so eventually you get a patient and you're like, okay, you know, we know what we're doing. We've practiced this. And I think that is the key. You know, in healthcare, you practice and plan all the time for these types of scenarios. And when something hits, you know, you say, okay, I am ready as I'm going to be, and I'm going to evolve as time goes along. So it was more of a, like, we got this, we can handle this, and we're prepared to take care of our patients.
Okay, so you did talk about the fact that you had a pandemic plan. Did you follow that playbook to a T? How did you begin to change the way your hospital operates to deal with COVID patients while also dealing with day-to-day stuff?
Sure. So you have a pandemic plan that's sort of a framework, and then you update it based on whatever the disease or illness is that you're dealing with at that time. So in this one, it's like in most, that you said it. You need to keep COVID patients or those potential COVID patients away from the rest of patients. So we did a variety of things. We opened an alternative testing site in the Plaza 15 across from us, kind of in a remote area, so that if you needed a test and you were armed with physicians' orders to have that test done, you could be swabbed from your car, you know, driving into that site. We also sort of locked down the emergency room. So as you approach the emergency room, you're asked a series of questions, and you're either allowed to enter because you're there for non-COVID reasons, or you would go to an alternative exam site, which was attached to the emergency room, but you didn't have to enter the emergency room to get in it. And you could be checked and tested there without ever entering the facility. And we actually had an expanded area set up in a tent, because there were times we had sort of been hitting capacity in that alternative exam area. And then internally, you have a COVID ICU and a regular ICU located in different locations. You have the same thing with sort of medical units where you don't need the ICU care, but you may test positive for COVID. So you begin to separate them. And for us, we also are in the midst of a building project in which we're going to have much more negative pressure rooms in our ICU, but we did not have them. And we only had one in the emergency room. So the staff here engineered more negative pressure rooms so that we could handle more critically ill patients because it was highly recommended for respiratory reasons that you're in a negative pressure room. But we expanded our ICU capabilities and our other COVID patient room availability significantly, which is what you're tasked with in this type of crisis.
Dr. Rue, I guess one of the more disconcerting visuals of this virus was to see the tents outside of hospital facilities. I know sometimes they're set up as part of drills for pandemic drills, but that had to be that was pretty alarming for the general public, I'm sure, but all part of the plan, wasn't it?
Yeah, and we've stood up the tents before in times like these when we anticipate either an infectious orientation where you want to create separation of the ability to evaluate and test people, or when you imagine surge capacity needs where you're anticipating big volumes and you just need in a very quick way to prop up some extra space. And so we put tents up across all of our campuses, and our preparedness efforts were very similar to what Kendra just described over there. It was about focusing on creating separation, creating the right surge capacity plan, and at the same time, as we mentioned earlier, the postponing or the canceling of elective procedures and non-urgent clinic visits, it created extra capacity, not just in terms of space, but in terms of staffing that then we were able to reassign across to other areas. And so that was all a big part of the effort. I think the other is having less activity in the hospitals and in the clinics allowed us to make the right changes from a physical plant standpoint, whether it's creating more negative pressure environments or even getting the right equipment and supplies to the right places. I think that's a lot easier to do when you have hospitals that aren't running totally full the way that they might be used to, but instead, running at 2/3 capacity or half capacity, something like that. It allows you to create those extra spaces. And so it was all of those things coming together as far as, creating a different operating model in a very short period of time.
You talk about staffing. Go ahead.
I would add to what he said that is also why there's a challenge in coming back up, because you've redeployed the spaces in the hospital that became available because you weren't doing the elective surgical cases. And now you've used those for some other things. You've got to begin because you still have to balance the COVID, non-COVID patients. So it is partly why you have to take a measured, purposeful approach to coming back up, because you've taken away some of those spaces.
So Kendra, how did your staff handle the situation? Did you have any issues with staffing? And the third part to that question, and I don't know if you can or are willing to say this, have any of your staff contracted COVID-19?
Sure. So from a staffing perspective, I'm in a situation where I have a fixed staff of people and I don't have a larger system. So in order for us to handle this financially, right out of the gate, we furloughed about 265 people that we considered sort of, you hate using the word non-essential because everybody's essential, but that were considered in this time non-essential to the work. And then about 60% of our workforce was impacted by reduced hours or were furloughed. So we had a significant impact to our staff. But from a clinical perspective, we have enough staff, and those are the individuals that stayed here. And you look at clinical staff coupled with things like food service and environmental services and all of those things. Those are all essential. Your respiratory therapists, there's still a whole support system to all of these individuals that you keep. But we felt all along like we have staff. But in rural communities like this, you really do just have a fixed amount of staff. When people talk about these alternative sites that are developed, neither of us really have the extra people to send out to these sites because you're using those people to take care of your population, and you need to have a second and third wave of people in a true crisis that comes from your own people. But we felt very good about the staff that we have. And from, you do everything in your power to keep people from getting COVID. But yes, we have had people test positive for COVID, certainly not a lot of people. And there are some that maybe would have contracted it from the few patients that we have. But it was also people who contracted it outside of the walls of the facility. So we have had a few people test positive, but very few.
Dr. Rue, what about the Geisinger staffing? It seems like you had a very good staffing situation there. How has your staff handled this situation, and did any of them get the virus?
Yeah, so similar to some of the things that Kendra mentioned, our staff have held up great. I mean, it's something that inspires and really I find totally uplifting is just the adaptability of our workforce. I mean, let's all recognize that this is something that has impacted not just their work environments, but their home lives as well, whether it's, kids being out of school and figuring out, how to arrange for childcare, or spouses, depending on where they work, having different kinds of work environments or situations, or loved ones maybe being afflicted with the illness. I think all of those things have held true. And so it's a tough time for everybody, not just from a work standpoint, but from a personal standpoint. We've tried to recognize that while at the same time balancing the reality of keeping our operations going. We have had staff test positive. I believe our number, don't quote me on this, is 89 or 90, thereabouts. But that's out of a Pennsylvania workforce of 26,000 staff. So the numbers are still pretty low, and the majority of those, believe it or not, we believe to have contracted the virus in the community, not in the workplace. And we know that from questionnaires that our employee health folks walk them through. We do have staff that have spouses or families in the New York or Philadelphia markets, and they were coming back and forth for some time. So some of those, or that had traveled to some of these more endemic areas across the world. And so we think that's been a more likely source of some of the infections. At the same time, we also know that 4 of our employees have been hospitalized, but they've all been successfully discharged and have made a recovery. So thank goodness. But the other thing that we keep an eye on is what is the rate at which our employees test positive relative to the rate at which the broader community folks that we test as patients test positive. And believe it or not, our employees test positive at half the rate of the rest of the patients that we test. And this is all still criteria-based testing. And so we think that's a reflection of people taking the right precautions in the work environment. And at the same time, I think I would be remiss if I didn't mention something about how our staff had just been super innovative and creative in terms of problem solving in the workplace. And it's all been about change and adapting to change and getting folks comfortable with that and trying to be as transparent as possible with information. So we have regular town halls on a virtual basis with all employees, all providers, and with the community. And so we're trying to get information out there because it's what we talked about before. We're all in this together, and the more we can do around precautions and preventive measures, that's going to benefit everybody. And that's the approach we've taken with our employees as well.
Can you say offhand how many cases you've handled total? Do you know offhand?
Yeah, well, let's see. And again, don't quote me on this, but I believe the last numbers I saw, we had 14 or 15,000 that we've tested. And then of those, about 15% have returned positive. And of those, about 15% have required hospitalization. And so I think the overall number that we've hospitalized has been, somewhere north of 300, I want to say. Of which about 100 remain in the hospital today as it stands, or a little more than that. And so that's the rough breakdown of how many have we tested, how many of those have turned positive, and of those that turn positive, 15% or so of those requiring hospitalization. It gives you an idea that still 85% of those who test and have symptoms test negative. And of those who even test positive, 85% of those never need hospitalization. They do fine recovering at home. And even of those who get admitted, the vast majority of them make a stellar recovery. So I think that's important to keep in mind, while at the same time not losing sight of the fact that this is a serious illness. It can be devastating. It does kill some folks. And so we've been trying to deliver those facts because it truly is a balanced picture. There's no need for panic, but there's absolutely a need for taking precautions. And so that's the balance we've been trying to strike.
Can you talk a little bit about some of the symptoms? Are the symptoms pretty much holding true? The cough, the fever, the tightness in the chest, or have we seen some more symptoms beyond that?
Yeah, so we've said that it's generally tracked along with what would traditionally be called deeper respiratory illness symptoms versus upper respiratory illness symptoms, which would be more what you would see with a common cold. So runny nose, stuffed up nose, cough, fever, sore throat, that kind of thing. This has the fever, has the cough, but the cough is typically non-productive. And we also see, I think a lot of people come in reporting just body aches, muscle aches. I think you all have probably read quite a bit about loss of smell or taste. And then recently, we've also noticed that there may be a pattern, and still early to tell, around something to do with blood clotting. And could it lead to people clotting blood more quickly? And of course, that could put them at a risk for stroke and otherwise. I think that's been mentioned in the media. We've certainly seen cases of it, but to what extent, I think those are for the epidemiologists to decide, and it still is pretty early in the disease course. One of the reasons why we absolutely need to study this thing and keep a very scientific eye as we look at studying not just the symptoms, but also the treatment and the efficacy related to that.
So when a patient comes into your hospital and tests positive for it, what is the course of treatment, if you can talk about it, that you take the patient through from that point on?
So we make an assessment based on their clinical picture. If they're adequately oxygenating, I think is the key. And if they're able to oxygenate, they're not short of breath, they're able to have their activities of daily living, they're able to go home, pretty reliable home environment, I think those folks are safe to go home. But believe it or not, what we do is anybody who tests positive, we have a nursing coordination team that typically we use for closing care gaps. So think of this as the folks who would outreach to you saying you're due for your colorectal cancer screening, or for your diabetes screening, or for your measuring your blood pressure. That same outreach team is now outreaching to anybody who tests positive but is safe to go home, so that every day we reach out to them and monitor how they're doing. And now we're also sending them home with the ability to do remote monitoring on things like their blood oxygenation levels, so that at any turn for the worse, we're able to bring them back in for reevaluation and potentially for admission in the hospital.
Okay, Kendra, so at this point, how many cases has EVAN handled? Do you know offhand?
So I was just looking, we've tested 737 people. We have had 75 positive COVID patients, and we've got about 44 tests still pending. So while we have the ability to do some on-site testing, for those people whose symptoms aren't, an emergent type situation, it takes us 24 to 48 hours to get tests back from the reference lab. So we still have 44 that we're waiting. But if you take those percentages that Dr. Rue mentioned and apply them, we fall right within that band. So, you're looking at 11 to 13% of those we test end up having COVID. And then we have the same types of statistics of people who end up being hospitalized. And you have those that are critically ill and those who are on the borderline that you're just watching them. So like right now, today, when I looked, we have 4 patients in the hospital with COVID, 2 are in the ICU, and 2 are on the COVID unit being monitored, but do not require critical care. So we have 4 people in the hospital right now. So statistically, it just falls right in line with the percentages that he gave you. We just deal with a smaller number.
So we talked about separating day-to-day patients from COVID patients, that whole process. How have you in your hospital facilities kept the COVID patients separated from the general public?
So I think I described for you the way in which we manage from the emergency room perspective, but when you get admitted, we have what used to be our regular ICU is now the COVID ICU. And we have moved regular ICU patients down to our PACU, which is right outside of the ORs, where we manage patients post-operatively. So that is our regular ICU. And then we've taken our step-down unit, which is outside of the ICU, and made that our COVID ICU. And where we used to do orthopedic recovery of patients, we have a unit there. That's where we keep our non-COVID medical and surgical patients. So that's kind of how we've gone about it. So one floor has the COVID patients and one floor does not have the COVID patients. And then you don't cross-utilize staff. You know, those people assigned to the COVID units stay on the COVID units, and those patients assigned to the non-COVID units stay, or those staff assigned to the non-COVID patients stay there. And that way you're never cross-mingling staff as well. So that's somewhat how we do it. And then you temperature screen and monitor anybody who comes into the facility for something else. So if you are coming in to have an image done in our imaging department, or you need blood work done, when you come in, you're temperature checked, you're asked all the screening questions, and you're not allowed to take anyone with you, but you go to your test and then you leave. We temperature monitor and screen all of the workforce as they come in the building. And so those are just some of the ways in which we try to make sure, you know, we're monitoring everyone that's in the building, but you really make a purposeful effort to keep everybody separate.
Is that a similar situation with you, Dr. Rue, at Geisinger?
Yeah, it is. It's the same approach. It's testing and screening everybody when they come in the door. We went to universal masking on any of our campuses. In fact, even in an office environment like this, if it weren't for the fact that, you know, we're on camera here and there may be some lip readers and otherwise, or facial expressions are important, obviously, I'd have my mask on as well. In fact, you know, here it is. So we did that as well. I think, yeah, there you go. So I think this is part of the new normal. And then as far as the patients who are COVID positive, very similar approach. You know, there are certain wings or units that are designated for the COVID positive patients, both on the ICU side and on the general floors. And partly this is practicality, because when you're able to do that, you have the same staff that you're able to train in terms of the kind of equipment, how to put on the equipment, how to take off the equipment, and the kind of precautions they need. And it makes it easier to do when that's a consistent staff that's seeing those patients in those units. And so that's been one thing. The other is it also creates the environment from a personal protective equipment standpoint for people to have to put the gear on and take it off less often because they're in the unit, they don the equipment, versus if it was all intermingled, they'd be doffing when they're off with a non-COVID patient, donning again. And then Kendra's point, which is spot on about it also minimizes the potential risk of spread. And so it's all of those factors, which is why we've taken a very similar approach around separation.
It's interesting when you talk about donning and doffing, these are all terms we're learning about. PPE, most of the general public never heard that term before, N95 respirators, face shields. So one of the big issues and one of the main concerns all along for hospital systems has been PPE. How has Geisinger done in that regard, and do you think you were prepared enough?
Yeah, I think a couple things helped us, and sometimes, hey, we'll take it. Better to be lucky than good. But we got a great lab team, and I mentioned it earlier, our lab team, I can't say enough about the capabilities that they created around being able to do that on-site testing. Early on, that was an absolute godsend when it comes to being able to conserve our PPE. And so I think that helped us. And then the other is the preparedness efforts going back to January. Probably before COVID was on the tongues of all of us, we had this team that was managing that in conjunction with our supply chain team. And so they had a little bit of a head start of a month or so plus before things really got into full gear. And I think that helped us as far as supplies. At the same time, and Kendra referenced this earlier, the community has really stepped up. I mean, donations both big and small, from companies as well as individuals. People have just been really supportive, and the outpouring of donations, whether it's in terms of supplies or otherwise, I think that's really helped the effort as well. Construction companies, local pharmacies, I mean, there's been a lot of things that have worked out. And then as we've done all of those things, we've been able to get our supplies to a point that we think we can continue to manage. You never feel good. It's one of these things that, you always could use more. But at this point, we monitor it not only daily, it's hourly at this point, and we feel pretty good about where we're at.
Kendra, what about you as far as PPE for EVAN?
Sure. We feel like we're at a good spot. I mean, we went into it the same way. We had been working our supply chain aggressively even before we took these steps. We've had, the fact that I believe the social distancing and the actions across the state and in this region have helped keep it down. It has allowed the supply chain to replenish some and get additional stock in. And we've had the same exact thing that Dr. Rue mentioned in community support businesses who have access to face shields and N95s, who are donating them and giving them to the hospital. And, one of the things that we did not get into here, but, we in this region have several unique communities that are part of the population we have to care for. One is the prison population. The other is the Amish and Mennonite community. And if you get a spread in either one of those populations, you could be overwhelmed as the health system. And so we were able to work very closely with the Amish and Mennonite community in having them understand COVID and how it could be spread and really the importance of social distancing in their daily practices. And through that, we were able to engage them in the making of masks for us. And so what we give out to the public when they come in, what we're able to give to our workforce for when they're not working, instead of using, the stuff that is considered PPE for when you're in the hospital, we're able to give out cotton masks. And it's really been a nice way for them to engage in the community with us and to also help realize that they could really have trouble in their community without proper social distancing.
And you also, to a certain extent, were able to tap into the expertise of Bucknell Engineering and even some volunteer efforts in the community.
Sure. Yeah, there's a group that I got connected with early on. It's actually consists of a lot of community members, several physicians who happen to be employed by Geisinger, who sort of started out two phases. One, they were really able to source their contacts and get regular PPE through different supply chain avenues that really benefited Geisinger and also benefited EVAN. But they've also on their own then started down a path of looking at alternative type PPE. And in my organization, when you look at what you have and then you look at the depth of that, I can go down the path of really out of the box thinking. I don't have a research arm tied to me that says, everything kind of has to be evidence-based. And while that is what you want to do and always follow in healthcare, in a time of crisis, I felt like I needed to make sure that I had alternatives if we became overwhelmed. And so I worked with this community group and they connected us with Bucknell in the development of some face shields and, a variety of other avenues to get sort of what I call backup PPE that you hope you won't ever have to use, but you have it if you do. And, it's sort of back to what Dr. Roos said about innovation and what happens to people in a time of crisis. And I think you find in healthcare that, they always talk about in the heat of battle, some people freeze, some people run away, and some people run in. And in healthcare, this is more mind-blowing than most people ever would have imagined in their professional life. But they run in, and that exhibits itself in many ways. And this group of people who sort of ran into this notion of how can we innovate and do some different things and really connect some interesting sources. I've been very happy to, have been brought in and been part of that, out of the box innovation.
Dr. Rue, you alluded to this earlier. Is there still the thinking that there's a peak out there yet? Or is the curve kind of flattening for us? I know parts of your system have been hit pretty hard, but where you're sitting right now today hasn't been overwhelmed as far as I'm concerned, for maybe the Valley, Montour, Columbia, Union, Snyder counties. Do you think there's still a peak coming? If not, has the curve been enough that you've been able to manage it?
Yeah, I think it kind of depends on what you might want to call a peak, I guess. But we think there's a peak for every county or area. It's just the good news is our projections, the latest ones suggest that peak is shorter meaning flatter and farther out in the future than what we were earlier projecting. And that means that the efforts of the community are paying off. So that's a great thing. But at the same time, it doesn't get you away from the fact that you will slowly, gradually see more and more cases. And then it kind of plateaus and then gradually comes down. I think that dynamic is going to be something we see in each and every market. And for us, it started with the Northeast, so Luzerne and Lackawanna. And the good news is we've seen the early signs of that curve also flattening and starting to decrease. But all of the things that we have in our projection models suggest that after that, you have this cascading effect of every 3 or 4 weeks, the next county and then the next county and the next county. And it's sort of, I've described it as the good news. We're not talking the Rocky Mountains where the peak is like this, but think of this as the rolling hills of the Ozarks or something where you have a lot of these mini humps across each of the markets. And that's what we think we're going to see even rolling out into these summer months and beyond.
So with that in mind, do you agree with the governor's plan his phase plan to bring the state back online?
I do. At the end of the day, I think it's one of these things. We used to talk a lot about, well, what does the post-recovery look like? And now I think the language, even internally here and more broadly, is shifting to, well, what does the recovery period look like where you're still going to have to manage in an environment where COVID exists? It's going to be here in some way until you have a meaningful vaccine. And so you're still going to have to make the precautions or take the precautions and make sure that we don't let up on those efforts. But even despite that, there are responsible and thoughtful ways to reopen segments of society. In the same way that we were talking about responsible and thoughtful and safe ways to reopen to certain elective procedures. So that world may look a little different. For example, if you work in a manufacturing plant, could it look like fewer people at work at a given time and staggered shifts and staggered lunch breaks and all of that? I think that's the kind of thing you're going to see. If you're in a shop or a restaurant, limiting to how many people can be in an environment at a given time, everybody obviously masking or screened at the door. I think these are the kinds of things that you're going to see interspersed with a thoughtful model of how to reopen segments of society.
Kendra, what about you? Governor's plan to bring us back online.
Sure, I support it. I think it's a very hard time to be a state or local leader. And you got to start somewhere, and you're battling something that most people can't see. And there's a lot of people who have differing opinions about it. And so economically, it's been a huge disruptor, and people want to get back to normal, so to speak, but I don't think it's going to be normal in the way that people hope, at least not right away. It's going to take a period of time. And so I think that a measured, purposeful approach to how you come back is the right way to go. And but it's very hard to lead through those times. And so I think that I support the governor's plan, and they're trying very hard to get people back to this new state of normal.
So Kendra, as a healthcare system, what are the challenges you see moving forward? Do you ever return to normal operations, or you just accept the fact that there's a new normal from this point moving forward?
I think it's a long game, and it's going to take a while. And so I think part of why you ramp up your operations slowly is so that you can sort of assess it. As the economy comes back up, what does that mean? We treat people in our organizations regardless of their ability to pay, meaning it doesn't matter if you have health insurance or you don't. That's part of our charitable mission. But it does have an economic effect on the organization on top of the already difficult economic effect we've had from shutting down for the last 6 weeks or so. So I don't think that for a while you could ever say you're going to come back exactly to the way you were the day that we all shuttered our operations and headed in a different direction. But, we're here to take care of the community, and this community needs healthcare. And so I think it's a phased, ramped up approach. And so I think we don't quite know what we don't know. I mean, we've started to say lessons learned. And I think Dr. Roos said it once in his remarks, you're starting to formulate lists. Like this type of call, if you would have told me that I would spend the majority of my day doing this, I'd be like, I like being in person with people. I like seeing how things are. But this is, and I think we've seen, and, we're going to be able to study efficiencies. And I have meetings that go much quicker online when you're in person. And, you've got little lists of just tiny little things like that I think will change how we conduct business. How we treat patients. I think the customer, the patient, we're all doing, Geisinger was ahead of the curve in telemedicine, but we've all very quickly moved into telemedicine platforms at a very aggressive rate that I think the patients will begin to say, if you can do that in a crisis, why can't I do that in regular time? And then all of the payer systems and all of the things that support that are going to have to innovate and change to consumer demand. And I mean, you could go on, but we will not be back to what we were before this started. And I think some of the scientific innovation, I bet you the government will look at their stockpiling different, I think, than, testing. There's just so, you could spend a whole day just talking about the changes I think that are coming.
Yeah, Dr. Rhee, you talked about some of the new normals we'll be dealing with here in the coming weeks, but I'm sure maybe months and even years into the future, things are going to change.
Yeah, I think the change is here to stay. It really is a new normal, is what I would say. I would agree with exactly how Kendra characterized it. I think if we're looking for, will things snap back to normal as they were pre-COVID? I don't think that's happening. To me, it's more of a question of how long does it take you to settle into the new normal? And I think the answer is months, if not years. I mean, there's going to be a lot of dynamics and longer lasting impact of COVID in ripple effect ways that we probably aren't even aware of today. And some of it gets to consumer behavior and expectations. Some of it gets to the broader macroeconomic kind of landscape. And then some of the transformative changes that have happened because it's been necessary. As the saying goes, necessity is the mother of all innovation. And I think we've seen that. Telemedicine, great example that Kendra raised. That's the kind of genie that you tend not to put back in the bottle. And I think that's what we're going to see going forward.
Okay, so I know I've kept you for a long period of time, and I know you're both extremely busy, but we've been ending our segments with touching base with feelings here. How are you handling this personally, Dr. Rue?
Well, I think it's been an interesting time, to say the least. But I really go back to what I said earlier. We are really all in this together. And in a strange way, this has been a reminder of that. Whether it's things that our community is facing, we've kind of just taken the approach, and I think it's the right approach, that it's only a matter of time until that becomes Geisinger's problem. And it's only a matter of time until that becomes my personal problem or our personal problems. I think we're all so intertwined in this in ways that people may not even realize. That personally, I kind of feel like this notion of team, and I feel support, and I feel like it's a galvanizing moment for our communities. And so it's a good reminder, because sometimes in the day-to-day, we lose sight of the fact that whether you're talking about Geisinger or a personal human being, we're all functions of our community at the end of the day. And I think this has served as a neat reminder of that. And in a weird way, I find that to be both inspiring and encouraging.
Kendra, what about you? How are you doing with this personally?
I think that I've been doing fine. I mean, I work a lot anyway, so I've just accelerated the pace of how much work that I'm doing. I have a Peloton bike, and so my Peloton bike early in the morning has saved me in that's how I'm getting my exercise and keeping my mental health where I think it should be. But I couldn't agree with Dr. Rue more. I mean, I'm blessed to be able to lead a community hospital, and I have never felt more supported by the community than I have in this last 8-week period of time. And even as an individual person, as a professional, I've never felt, I've had so many people reach out in so many different ways. And even with my own family, I connect with my family differently than I did. You know, I have 2 daughters and their families that live away. And, you know, we now do this type of call, which we didn't do before. And I don't know why, but I actually physically get to see them. And so I think that it's really, you know, there's never been more of a purposeful time to sort of be in your head, I guess I would say, and to be quiet with yourself in many ways, and be quiet with those people that are around you, so to speak, and really reflect on what matters. And, you know, I talk about it with my team about, you know, we'll look back on this and how we conducted ourselves, and you really need to lead yourself, you know, to that higher purpose, to that higher humanity, and conduct yourself in that way that you'll look back and say, I'm proud of, you know, what my organization did. I'm proud of how my team functioned and how we serve the community.
Okay, thank you very much. Well said. Thank you to Kendra Ocker, the President and CEO of Evangelical Community Health Hospital. Thank you, Kendra.
Thank you.
And thank you to Dr. Jaewon Ryu, the President and CEO of the Geisinger Health System. Thank you very much.
Thank you, Chris.
And that's going to do it for this special series episode of Conversations on COVID-19, part of In Your Neighborhood. I'm your host, Chris O'Rourke. Thanks for joining us, and stay safe out there.